Well, thank you everyone so much for joining us today for this really important webinar. That we are pleased to present this to you all, focused on increasing equity impact in community-based nutrition research. We have a wonderful panel lined up for you all today. And I just wanted to start by introducing healthy eating research. We are a national program of the Robert Wood Johnson Foundation. We are based at Duke University, and we have three primary program goals, which are to really establish a research base on policy systems and environmental solutions that advance health equity in the areas of diet quality and nutrition, to build a vibrant multidisciplinary field of research and a diverse network of researchers working in this space, and to ensure that findings are communicated effectively to inform the development of solutions with the goal of promoting health equity. We have been around as a national program of the Foundation for 15 years. It has long been a goal of ours to incorporate an equity focus into everything we fund. And in recent years, we've really been trying to provide more guidance for our grantees and our research network centered around just how to do that. Many people know the importance and the prevalence of health disparities when it comes to diet quality and obesity. And we have, continuing growing body of evidence on how social determinants of health really impact the upstream choices that lead to people's abilities to lead healthy and happy lives. And we feel like today's webinar is a really important point in providing more on the how to incorporate equity into your research. I'm going to kick us off very quickly with just a couple of logistical points. All participants have been joined in listen-only mode. If you have any tech or logistical questions or issues throughout the webinar, please put those in the chat box. We have people on hand to monitor that and assist you as needed. And if you have questions for our panelists, we will be doing questions and answers at the end of the webinar. We will have about 20 to 30 minutes for those. Please make sure you're entering those into the Q&A chat box to the right of your screen, not the chat box. We will, again, monitor and filter those and be sure to get to as many as we can. And following the webinar, the recording and slides will be available at the Healthy Eating Research website. So with that, here's our distinguished panel joining us today. I'm going to let our moderator, Angela Odom-Young, introduce all of them for you momentarily as they are speaking. But I just wanted to start by introducing Angela, who's a longtime member of our National Advisory Committee and a wonderful colleague. She is an associate professor in the Department of Kinesiology and Nutrition in the College of Applied Health Sciences and associate director for education and research in the Office of Community Engagement and Neighborhood Health Partnerships at the University of Illinois at Chicago. Her work examines social, cultural, and environmental factors that contribute to disparities in diet-related health outcomes in low-income communities and communities of color. We are thrilled to have Angela moderating today's panel. So welcome, Angela.
Thank you so much, Megan. I'm very excited about the webinar today. My job is to really just frame the comments of the panelists and talk a little bit about equity and why it's important that we bring that equity lens to nutrition, physical activity, and obesity research. So I wanted to start out, when we think about equity, this quote from an interview with David Williams, who is a professor at Harvard, in an article, Health Disparities in America, that was done by the American Psychological Association. I think these comments really embody why it's important to take a look at equity. He says, racism affects health in profound ways that are over and beyond any of the measures through systems that have been built up over the years and are now locked in place, replicating social inequality. Race is not a useful genetic category, but it's a profoundly useful social category. What race we belong to tells us more about our society than about our biological makeup. At every level of income and education, there's still an effective race. Even wealthy Black Americans are statistically less healthy than affluent white people. Health disparities are large and persistent over time. About 220 African Americans die every day in the United States who would not die if their death rates were similar to those of whites. And so it's important, and again, his comments are about race, but we can look at other types of issues through an equity lens, whether it be heteronormativity, disability, income inequality. And so it's important that we bring this lens to our work because it gets at those root causes, as Dr. Williams mentions in this quote. So today, I'm just going to give an overview, really get us on the same page when it comes to terminology, and highlight the definitions of health disparities, social determinants of health, health equity, and health inequity. Provide some comments about why it's important to look at diet and nutrition through a health equity lens, and then how do we do that? And really just to get started with that, the panelists will dig deeper and highlight some examples from their work about how to really apply this equity lens to research. So what are the definitions of health disparities, social determinants of health, health equity, health inequity, and I even added structural determinants of health. So many of us have seen these definitions. So we think about health disparities. For many years, there's been a focus of health disparities in the U.S., both from a national perspective, and I'm sure a lot of you look at health disparities in your work. So health disparities are really those differences in the incidence and prevalence of health conditions and health status between people, whether it be race, socioeconomic status, sexual minority status or sexual orientation, gender. But health equity, and looking at these issues from a health equity lens, acknowledges that these differences are avoidable. So avoidable differences in health status or distribution of health resources between population groups within countries or between countries, that's systematic and unjust. And so it takes a justice framing, indicating that these differences, they're not just by chance, but they're avoidable, they're systematic, and they're unjust. So health equity is when everyone has a fair and just opportunity to be healthy. This requires removing obstacles such as poverty, discrimination, and their consequences including things like powerlessness, lack of access. So health equity is when everyone has that opportunity. And social determinants of health really brings this to a place-based perspective, where you look at place-based social and economic in which people are born, live, age, work, play, worship, and how those place-based resources are distributed differently across communities, across populations. So things like material circumstances, housing, a neighborhood quality, financial means within communities, like community businesses, access to employment. And these are rooted in the structural determinants of health. So hierarchies of power, prestige, they control those access, they control that access to resources. So why is it important for us as nutrition and health professionals, public health professionals, to look at obesity and diet through a health equity lens? And the first is disparities. One, we know there's differences, but again, if we think that these differences are avoidable and unjust, we can't just look at the differences, but we have to acknowledge that these differences exist. So that's the first step. And this is some data, national data from NHANES that highlights those differences in dietary quality. I would be remiss if I didn't talk about sort of the U.S. food system overall and consumption patterns overall before I dig into disparities. We know in the U.S., based on the availability of ultra-processed foods, that most Americans don't meet those guidelines. So fewer than 1 in 6 adults are consuming sufficient amounts of vegetables, fruits, seafood, whole grains. So we know that in the U.S. that people fall short of those recommendations. But this is by race. We also can think about income. African Americans in several categories, in some categories, but not all, Latinx populations also fall short of the recommendations when you look at whole grains, sugar sweetened beverages. So in America, we're falling short of those targets. You can see by race and ethnicity the disparities that exist, where certain populations are falling even further short of those recommendations and are doing worse. This also links to food insecurity. We've heard a lot about food insecurity in the recent months based on COVID, but we've always, even though we've seen a decline over the last several years in food insecurity, when you look at national data, the disparity has continued to persist. So this is the prevalence of food insecurity by selected household characteristics in 2019. And you can see by both race, poverty, household structure, so single women with children, families with children overall, they have higher rates or higher prevalence of food insecurity as compared to all households. So again, you have this persistent disparity across many years, even though there has been a consistent decline prior to COVID. So this is even further highlighted when you think about food insecurity during COVID, because populations that are more at risk for food insecurity, even prior to COVID, have now a higher prevalence. Here in Chicago, it's been highlighted by our food bank that they're seeing a 120% increase in the number of people that are in need of charitable food assistance based on the COVID pandemic. And this is data from a report that came out from Northwestern. And when you look, again, we're seeing a higher rate of food insecurity during the pandemic if you look at all respondents. But again, that disparity by race and ethnicity has continued to persist, and populations that were already disproportionately at risk are even more at risk. And we are very familiar with disparities when it comes to obesity by race, so I won't really go into great detail. But again, you see that disparity in the prevalence of obesity in both children and adults by both sex and race and ethnicity, specifically Hispanic origin. Same with income. Again, this is not new. We know that these disparities have existed and continue to persist for many decades. And this just highlights the disparity by household income. And you can see, of course, this is from national data from NHANES. You see that difference in both males and females, the difference by income with lower income families or families with lower SES being more at risk. But I think it's important to also think about the intersection. Many times we just focus on race or we just focus on income, but you see a higher prevalence of obesity, for example, in children based on disability status. So children with developmental disabilities and autism have a higher prevalence or a higher weight status, higher prevalence of obesity as compared to their typically developing peers. There has not been many studies on sexual minority status or gender identity, but again, in adults, we see this difference where, as compared to cisgender males, for example, sexual minority male adolescents are at higher risk for obesity. And it's, where you see cisgender females as compared to cisgender females as compared to sexual minority females, you see the disparity in both children or adolescents and adults. And we need more work in this area to understand how sexual minority status impacts risk. But we also think about the intersection between these two. So people are not just race or not just income, but they have these identities in their intersectionality that may put some populations more at risk. So African Americans, and this data is seen in adults, African American and Latinx individuals that identify as sexual minorities may even be at a greater risk. So when we bring an equity lens to this work, we can think about race and we can think about income, but we also have to think about intersectionality and the idea that people may have these multiple identities that put them at risk for obesity or poor diet or food insecurity. So I want to talk a little bit about how this is rooted in social and structural determinants of health. There was a report that came out from the National Academy of Sciences, and this is about, this was focused on specifically around race and ethnicity and centered on how do communities engage in action that can contribute to health equity. They talked about how these determinants are historical and political, and of course they persist over the life course. And there are multiple levels. So we are very familiar with the socio-ecological model and how we apply that to nutrition, but the socio-ecological model can also be applied to issues of race and income and equity. So if you think about the interpersonal level, so things like internalized racism and stereotype threat and embodying inequities, interpersonal level, so that social network or that social level, overt discrimination and implicit bias. And this is where we have things like microaggressions that can lead to poor health. Institutional level. So again, it's not only that interpersonal and interpersonal level, but as Dr. Williams talked about, it really is embedded in systems and in structures and in policies. So things like hiring practices, being under or overvaluing certain populations at the community level, so differential resources, and then at the systemic level, so incarceration policies and things like immigration policies. And I'm just going to talk about a few of these. The two pathways that I wanted to highlight when I talk about just a few examples of how inequity can manifest itself within the context of nutrition and obesity. There's two pathways that were highlighted in the National Academy of Sciences report. One pathway is through differential treatment on the basis of race that disadvantages a racial group or any group. Again, the example that I'm using is race. So studies have shown things like racial discrimination limits people of color's access to things like education and employment. And then second, you can look at the treatment on the basis of inadequately justified factors other than race that may disadvantage a racial group. So disparate impact also has implications for racial and ethnic disparities. And this is one pathway through which income operates. So if there is some differential when it comes to income, that may not be discrimination on the basis of race, but because of certain policies that may have racial or ethnic groups overrepresented in that population, you also have this disparate impact, which also can impact racial and ethnic groups. So one proposed model, and this is just a conceptual model about the relationship between racism and health that highlights that linkage between racial discrimination and health outcomes, not diet specifically, but it includes and has implications for diet. And so I wanted to kind of highlight this in the role of racial discrimination, education and income, and discrimination and trauma. So if you look at the pathway through which racial discrimination, and keep the framing in mind about discrimination directly based on race, or where you have that disparate impact because racial groups are overrepresented in those populations. You can look at denial of goods and resources and services. So things like poor living conditions. We've talked in our area so much about quote unquote food deserts or food swamps. This idea that people have poor living conditions when it comes to access to food, but other broader living conditions like neighborhood crime or poor housing conditions can also lead to poor nutrition and diet related health outcomes. Decreasing quality or access to care. So, do people have access to care and nutrition services? Racial discrimination can have a psychological impact, and that can have a physiological effect again, which can link to those diet related disparities and conditions. And the last is that assault. Nancy Krieger really highlights this in her model in the eco-social theory, the idea that discrimination or these factors are embodied, they get under the skin and you actually embody them physically. And those factors are important for us to think about as we look at diet-related conditions. So I just want to highlight, and again, not to take up too much time, but for the framing, one is racial segregation. So among middle and upper income households, African Americans are more likely than Hispanics and whites to live in disadvantaged neighborhoods, even regardless of income. So middle and upper income African American households, 52% live in neighborhoods that are disadvantaged as compared to 44% Hispanic households and 11% of white households. So this idea that it's not just individual, but it's people that even may have higher individual income, but they're living in communities that have a significant disadvantage and they lack resources. We also see this translate into life expectancy. This was done by Robert Wood Johnson Foundation and VCU, where you see short distances lead to large gaps in health. So this was a mapping project around life expectancy. The left is New Orleans and the right is Chicago. This is our L system. Again, I'm here in Chicago. And so I'm very familiar with these neighborhoods where you have the differences in the Gold Coast in Chicago, which is more affluent. And then you look down the life expectancy of being 69 years in Washington Park, which is a predominantly African American community. And so even though I'm highlighting the focus on African Americans, because my work is focused on African Americans, you can look at disparities also by other types of demographics or groups that are impacted by these structural determinants. And so you see the same in New Orleans. The difference is, again, short distances leading to large gaps in life expectancy. Income inequality is yet another example. And income inequality, again, has persisted for many years. Pew released a study and indicated that the wealth gap between Blacks and whites and Latinx populations and whites, that white populations had 13 times the wealth of Black populations and 10 times the wealth of Latinx populations. And so we measure earnings, but we don't always look or think about disparities in wealth. On the left, the slide is earnings, and you see this is the median usual weekly earnings of full-time wage and salary workers age 25 and older. And actually, you don't see as much of a disparity in earnings at the high school level. So at the level of high school diploma, you don't see as great as the disparity as you see among those with advanced degrees. And this is by race and gender. So as you become more upwardly mobile, you actually see more of a disparity in earnings. And those disparities in both earnings as well as historic disadvantage as it relates to wealth translate into the right slide, where you have these large gaps and significant gaps in wealth across every educational group. This is a small slide, so I apologize for that, and I can always share. But this looks at children living in poverty for each racial and ethnic subgroup. And I wanted to highlight this because, again, I've talked a lot about African Americans because that's my focus, but wanted to highlight on the left is Hispanic and on the right are Asian populations. And many times, again, we look at just this larger group and we see that certain populations have a higher prevalence of children living in poverty. But when you break this down by subgroup, it tells it tells a more complex story. So if we think again about using the equity lens, we have to think not only about what's on the surface, but even dig deeper. So both Latinx populations, poverty varies significantly across each subgroup, and the same with Asian populations. So depending on the group that we're partnering with or that we're working with, it's important to understand the characteristics of that local and smaller subgroup or local community, not just the broader context or the larger population. And then also incarceration. We've heard a lot, again, in the popular media about the differences in incarceration rates between white and Black and Latinx men specifically. So if you look at the high burden of incarceration as well as policing in Black communities, you see it translates into higher incarceration rates. And that has higher incarceration within communities have implications for food insecurity, diet, and obesity risk. So how do we look at health equity through a nutrition, diet, and obesity lens? And I think we have to do both. We have to look at health equity. Again, maybe our ultimate goal is health equity. And how do we think about health equity through the pathway of nutrition, diet, and obesity, but also how do we use a health equity lens in our work as we look at nutrition, diet, and obesity. But for some of us, the ultimate goal is health equity through the path of nutrition. So part of it is our epistemology, and this was an article from Bowleg entitled Towards Critical Health Equity Research Stance, Why Epistemology and Methodology Matter. So it goes to the equity versus disparities framing. What is our epistemology? Do we really believe that these factors are rooted in these disparities, are rooted in social structures, in environments, or do we still have only that biomedical or biobehavioral frame? And so it's important, and she talks a lot about this in the quote about the legacy of how race, other marginalized social positions intersect with race to create social inequality. So similar to Dr. Williams, part of approaching our work with a health equity lens is to think about our epistemology. And so what do we really believe? Do we believe that it's social structures and that those social structures impact individual behavior, or is the focus on personal responsibility and rooted in individual behavior? And so it's important that we look at that epistemology within the context of our framing, and bringing a health equity lens means challenging those traditional epistemologies that we bring to our work. Robert Johnson highlighted 4 steps to achieve health equity. The first is to identify important health disparities, to change and implement policies, laws, and systems, and environments and practices to reduce inequities, in the opportunities and resources needed to be healthy. We need to evaluate and monitor efforts, use short and long-term measures, and then reassess strategies in light of processes and outcomes and plan next steps. So I know this work can be challenging. I think it's challenging for everybody. And a lot of people are probably thinking, where do I start? We go to our next speakers, we're going to dig deeper in this idea about how do I develop a research program that's responsive to health equity. But when we think about kind of where do we start, there's sort of four things in using a health equity lens. The first is grounding in shared humanity, reinforcing and resourcing decisions made by communities. So versus that top-down approach, the idea that communities can tell their own stories, have their own narratives, and then how do we resource and look at balances, rebalancing power, and make sure communities are powered to engage in that decision making. Shifting the role of power from reinforcing systems of injustice to equitable change. So sparking equitable change. And then address the internal condition of the intervener as well as the system. Many times we think about systems separate from research, but our system of research can also reinforce inequity. So I want to turn it over to Natasha Frost and Lindsey, where we can see some very practical examples of how this is done. Natasha Frost is a senior staff at the Public Health Law Center at Mitchell Hamline School of Law. She provides legal technical assistance to stakeholders around the country in developing effective policies to promote healthy eating and active living. Natasha has done extensive research in early care and education settings, including analyzing each state's child care licensing structure and developing several state-specific resources. Throughout all of her work, she seeks to identify how policies and systems impact health inequities and how law can be used as a tool for change. Lindsey is a social epidemiologist focused on cancer health disparities as well as the health impacts of and policy solutions of structural and institutional discrimination, especially at the intersection of public health and criminal justice. She is interested in the use of data in equitable policy and management. She is currently a research assistant professor at the University of Miami, Miller School of Medicine's J. Wise Institute for Health Equity at the Sylvester Comprehensive Cancer Center. And so I'm going to turn it over to Natasha.
Thank you so much, Dr. Young. Hello, everyone. Thank you for joining us today. And I really appreciate that we're able to come after a very big picture analysis of structural racism and how the systems really play into inequities and kind of bring us down to the point of what we as researchers can actually do in order to address some of those structural inequities and what role we can play. As Dr. Young shared, my name is Natasha Frost, and I am a lawyer and a researcher. I'm also a white cisgendered woman who is able-bodied, and that I bring that to the work that I do. I'm one of the researchers that was part of the Healthy Eating Research's pivot into the equity journey. I am part of a round 11 healthy eating research grant with my esteemed colleague, Dr. Erica Kenny. And as part of this work in the early care and education setting, we talked about and put into our proposal this idea of embedding equity into our project. And as part of that, of those conversations, I had this great idea of how to embed equity into the different pieces of the project, which involved a survey tool and interviews and some analysis of some resources on a webpage. And I thought it would be a great idea to get a group of researchers together who cared about equity and form a group that could help review the survey together. Now, spoiler alert, this did not work. I had to really face the reality that, like some of my very wise mentors shared, that was not the right course to really embed equity into a project. I had to actually acknowledge that my white privilege actually brought a lens to the work that would not allow that to get done without an expert. I had to embrace feedback from these wise mentors about the next steps of the project. I had to have humility rather than fragility on that I had taken the wrong path, and really let go of my ego in that. And so thankfully, Dr. Kenny actually knew of the perfect equity consultant and brought in Dr. Bailey. And so I am very excited that as part of this project, we were able to approach the survey tool and the other aspects with an equity consultant. So with that, I will kind of pass it off to Dr. Bailey to talk about what she brings to the work as an expert in equity consultation.
So hi there, guys. It is a pleasure to be here speaking with you. And I can just introduce myself. Besides being all the things that were listed already, I am a Black cisgendered woman, and I bring that to the table as well. Essentially, when I was brought into the project, I got the full story about what had happened up until that point. And really, some materials had been developed already, and other materials, were in process, right? So really, we jumped in particular, around a particular survey that was going to be going out. And part of that was looking at that survey and being able to retrofit that survey towards the end of thinking about equity, right? Equity broadly speaking. Essentially, what I had to kind of think about, if I take you through my process, is I almost have a litmus test. Ibram Kendi has a kind of litmus test, thinking about if the explanation or the question is focused on issues of the people, we have to interrogate that to see whether that's an actual racist idea that has been built into our discipline and how we do work. So essentially, for instance, in the field of epidemiology, which I'm a part of, I have to think about what elements of my discipline actually incorporate elements of white supremacy within my very thought, and being able to disentangle issues of methodology from issues of equity, right? So essentially, you can do better research by really tackling these issues. You're getting more at the issues that are of particular interest and make sense and make impact. And so that is where we are focused on. Oftentimes we talk about structural racism from a very kind of very theoretical standpoint about overall feeling. But obviously, if that were all that would happen or was needed, then we could take a training. We'd understand all the things, understand the white privilege. We'd understand the different structures that were built. We'd understand all of that, and then we would be perfect, right? But the next step is actually putting that into practice. And the whole concept of structural racism is recognizing that there are people who are within certain structures that were created and are structurally racist, but in order to not operate within that system of oppression, you have to kind of undo some of those elements, right? So research is no different than, going through kind of revisions of laws and thinking about voters' rights. other things like that. Our research is embedded within a larger system of oppression. So I think we can now kind of go into some of the questions. I thought this was probably we thought that this was probably the most useful component of our project besides just talking to you. So I'll hand off to Natasha.
Yes. So as Dr. Bailey said, I mean, really understanding that even though I've read books, I've done a lot of research on my own, I've attended different symposiums, I did not have the answers to effectively disengage from the white supremacy that is embedded in the research field. And I had to have humility in order to do that and let go of some idea that I could do this on my own. And again, pulling in the expertise of Dr. Bailey was really critical. The other thing that was really hard was that we had already come up with several of the questions. If I can share one piece of, if you don't take anything other than, humility, not fragility, take away that please bring somebody in early because it is very hard to retrofit an existing survey. We learn this in real time. And so you can see here that we came up with great questions that really fell short when applying an equity lens. And it was harder to actually apply that equity analysis and consultation when we had already created the survey tools versus if we would have brought Dr. Bailey in from at the ground level. So you can see here, and it's always kind of hard for me to see the slides and see what I had missed in the analysis. But that is white supremacy at work because it's embedded. It's like I'm a fish in the water of white supremacy. So I'm just really grateful for Dr. Bailey's analysis. And so you can see here we missed things about language and about culturally specific trainings. And so the kind of before and after consultation is a really important juxtapose between how an equity consultant can really transform the data that you're collecting. Dr. Bailey, would you like to go over kind of what it was like on your end to try and?
Right. So in looking at the question ahead of time, one of the key questions was around, okay, so we recognize that in-person trainings might be important and at different kinds of settings and how often might be really key. But in looking at this question, I said, okay, so if there's trainings that are offered, people might participate, they might not. What might interrupt that, essentially that participation? And who's going to be able to participate and who's not? Who's going to benefit and who's not? So essentially, we were able to kind of pick apart and think about whether trainings are happening in different locations. So oftentimes there's a centralized body that's then deciding, okay, we're going to have a training, but it might not be in a particular place where in this setting, it was early childhood centers, that might not be in the capital city of the state. It might not be anywhere close, right? So thinking about whether there are multiple different locations where that might be held, and then thinking about in what languages would those trainings be offered in order to fully understand essentially the state's healthy eating policies. You need to be able to communicate that in the language that people can identify with and understand, right? And then even beyond language, because oftentimes we talk about language instead of talking about culture, there might be other culturally specific trainings that might be geared towards essentially ways that people might be participating as an early childhood center, and how that might be a different kind of interface with the healthy eating program or policies. And then finally, there's a question around, are there any fees that childcare providers have to pay in order to have access to the training? And that might be a key barrier in some communities. So there's some modifications than just where and how often?
So we actually, the wonderful part about this process was bringing in Dr. Bailey to really talk through what the goals of the project were. She was able to identify questions that we weren't asking, because when you have, there's one part which is what we just walked through, which is having a kind of a retrofitted question. And it's just also equally as important to identify what questions aren't being asked that should be being asked. And so one of the pieces of information that we wanted to know is whether or not there was funding for training, but we hadn't asked the question in a way that was clear and that was specific to kind of how that funding was being provided. And based on Dr. Bailey's consultation, we were able to work that in.
And I think one element that was really important to this consultation specifically is around the fact that we were collaborative and we worked together. So we had a series of different calls between Natasha, Erica, and myself, where we were all on board, where we were trying to look at these things, and I asked questions about what the aim of the project was and how they wanted to, what they wanted to be able to say at the end of this project, whether they had that information, right? So essentially, as we were talking about training and fees and all of those things, then I took into account some of the elements around, there might be some technical assistance that could be provided, but from a state agency, there may be limited funds and they might be allocated to different other activities. So essentially, it's important to look, if you're looking at state differences and state variations, to think, are there specific trainings that are earmarked for training? And is there a kind of attention to the different kinds of childcare providers that might be there, or who might be less likely to have the message? So whether by location, geography, by access and marginalized status, so you're able to take into account a little bit more of what the actionable item is that can address this issue of equity. And so maybe I'll just continue, because this is another issue where essentially through talking about all of these things, we also talked about understanding whether a particular state official had a prioritization that needed to happen. As a former New York City employee, I know that there is a prioritization process happening. When we shifted at the health department into a kind of anti-racist organization, we're making that an explicit aim. Sometimes our priority was set by elements of equity, right? So you could actually ask in the process of doing their work and technical assistance to see what their view is on the level of priority that's being placed on technical assistance to different childcare providers. And so if you're talking about equity and you're prioritizing equity at a state level, then you would be thinking about whether the policies and the technical assistance around the policies, how they're impacting providers that serve predominantly families who are English language learners, whether they're serving predominantly low-income families, providers that are serving predominantly families from marginalized racial and ethnic groups, and whether the providers themselves are English language learners, right? All of those things are different kinds of technical assistance that would play a role in how equitable the changes to potential policy could be. So with that being an action-oriented research question, this allows you to start thinking further about equity. So,
all right. So we're going to be available for questions at the end. With that, I'd like to pass it back to Dr. Odens-Young.
Okay, great. Thank you so much, Natasha and Lindsey. Our next speaker is Carrie Jackson Cartwright. She is assistant professor in the University of Georgia Athens Department of Food and Nutrition, where her research is focused on early childhood obesity prevention. Her research agenda includes promoting wellness practices and policies in the early care and education setting. Carrie earned a PhD an MS in Foods and Nutrition from the University of Georgia, and she's an esteemed graduate of Howard University, earning a BS in Biology, and she's also a registered and licensed dietitian. So I'm going to turn it over to Carrie Cartwright.
Hello, everyone. Thank you so much for this opportunity and privilege to be here to speak to you today. I am Carrie Cartwright, as Angela said, and thank you for those words, Angela, and thank you for the other presenters for setting the stage. I am going to talk about my perspective of bringing health equity or moving towards health equity in the work that I do. And it's important to talk about that in a framework of where I work. I work for the University of Georgia. I'm an assistant professor. And just to give you some context about the University of Georgia, we are a land-grant university that was founded in 1785. I am from Atlanta, Georgia, but you can see here on this map, Atlanta is our capital city in Georgia. However, we are located in Athens, Georgia, which is about an hour and 15 minutes away from Atlanta. So we have our land grant mission, we have wonderful resources, we have a vast, beautiful campus, and we have about 39,000 students right here in our community. So one of the things that is important to note, though, is that within this setting in Athens-Clarke County, there is a lot of poverty. And so this is just an infographic that talks about the poverty that's in Athens-Clarke County, Georgia. And this data is a little bit older, from 2016, but now it's telling you that 64% of our students in middle school qualified for free or reduced lunch, but now under the community eligibility provision, all of the students in Clarke County actually receive free lunch because of the poverty rates in Athens. We also know that our graduation rate should be better. It's about 80%, and the poverty rate is 35% and growing. This is double the rate of the national poverty rate, and we want to work toward improving that. And so just letting you know that within the Athens community, there are many young people that are impoverished, and with the work that I do, thinking about food insecurity and thinking about promoting messages of healthy eating and healthy lifestyle, we have to acknowledge the poverty rate that is in the community and the fact that it is high. So I want to talk a little bit as well about the University of Georgia and a little bit of history. And so I start that within the framework of talking about Charlene Hunter Galt and Hamilton Holmes. These were the first Black students to attend the University of Georgia and integrate University of Georgia. And you see here it says Georgia Groundbreakers, and they were just that. They were brave students, very young. You can see them here being interviewed during the time when they came to the University of Georgia, and they were not welcome at the time, but they ended up doing wonderful things. Hamilton Holmes is a physician that was the first Black man to attend Emory University Medical School in Atlanta, Georgia, and Charlene Hunter Galt was the first Black person to write for the New Yorker and won a Peabody Award. Although Hamilton Holmes has passed away, Charlene Hunter Galt often comes back to the University of Georgia to work with our students. Now, I say this to say, I want to tell you a little bit about another person who was watching both Charlene and Hamilton when they had the courage to come to the University of Georgia and enroll in 1961. And her name is Mary Frances Early. And so in 1962, although she was already in graduate school at the University of Michigan, she decided that she would come to the University of Georgia for graduate school in music. And so she did that, and she actually became the first Black graduate from the University of Georgia. And when you graduate from the University of Georgia, it's bulldog country. So if you have 1 degree, you're called a dog. If you have 2 degrees, you're a double dog. And if you have three, you're even called a triple dog. And so I want to show you a picture of Mary Frances Early today. And if you're wondering why she looks so happy, it is because she's doing a tradition of ringing our chapel bell. And so here she stands, having her degree, being the first Black graduate, and she is ringing the chapel bell for a very special reason. And you see here our President Jerry Moorhead, actually standing here with her. The reason she is so pleased is because for the first time in the history of the University of Georgia, a college has been named after a Black person, Black woman, and her name is Mary Frances Early. So you see her here with the Dean of the College of Education, our Director of Diversity and Inclusion, and our University President. One of the things that is so special about sharing this story, the fact that she was inspired and that she opened up so many doors, it is because of her that I can be at the University of Georgia as a professor, and it is because of her that I was able to earn both my master's and PhD from the University of Georgia and stand before you today as a double dog. I was privileged to attend the gala that honored Mary Frances Early when the College of Education was named after her in February of 2020. I was able to go up to her and give her a hug and tell her that my mother sent her well wishes because she worked in Atlanta Public Schools, which I am a product of. So you can't imagine the pride that I feel when I walk by the College of Education and I see the name Mary Frances Early. And during that gala, they asked for everyone to stand that had been affected by Mary Frances Early, or the fact that they were able to come and get a degree because of the door she opened. And I stood and I beamed with pride and thanked her for her courage. And I thought about the fact that for many, many years this had not occurred, but it was able to happen, and it moves us toward equity. And so when I think about that, and I think about it in the framework of what I do, I have to acknowledge this because this allows me to do the work that I do in the communities where I work. And so when we think about an equity lens, thinking about working within communities and having an equity lens, I often think that we think we can go grab our equity lenses and put them on like our readers, look at our work, and then take them off when we're done and go, oh, everything was clear, I've got it done, and now I can remove them. But it's really not like that. You really have to steep yourself in equity, as Lindsey and Natasha just referred to, and it's an ongoing iterative process that requires training and much thought and much input from the community and the people that you are working with. And so I love this quote from Jeremy Everett that says, instead of rushing to solutions, we must rush to understanding. And to me, that really means that oftentimes, as academicians, as people working in the community with a health equity framework, we have great intentions. We want to go into communities, we want to help, we want to serve, but we rush to solutions without understanding the assets that the community brings, without understanding the actual needs of the community, without understanding just what it is that they would like for us to accomplish together with them, instead of serving them and telling them what we should or what we desire to do. Another thing, as a Black researcher conducting research in Black communities, that people think I have is just this. You see a picture of a golden ticket. Congratulations, you're awesome, it says. And people think, well, Kari's got it. She's a Black researcher. She's doing Black research in Black communities, so she doesn't have a problem with moving toward equity. However, it's just not that simple. And so just because I come into the community and I bring a certain amount of experience, I also acknowledge that I bring privilege, and there are differences in the communities where I serve and the way that they may even view me as a researcher, regardless of color. And so, one of the things I want you to think about and note is that in the community, I come in with the picture on the left where you just see me, and I'm a vibrant researcher, and I'm excited to do work, and I'm excited to serve. But what they actually see is the University of Georgia. They think about the history that I talked to you about, and the community members here. Not everyone is pleased and happy with the relationship that they have with the university. And so, with that, I have to also break over those barriers or overcome those barriers in the community and let them know that I value them and that I would like to have an equitable approach and I want them to be at the table when I'm doing planning. And I'll give you several examples. So one example is through one research project that I work with called Healthy Childcare Georgia, and it's a part of UGA SNAP-Ed, our SNAP-Ed grant. And when we started very early on, starting to build my community partnerships within the state, I went to different childcare centers and homes, and we were starting boots on the ground. We didn't have a systems approach at the time, and we just wanted to talk to people and get in the door. And there were several centers that said, absolutely not. You're from the University of Georgia. The University of Georgia has not given us resources. The University of Georgia has not treated us well, and you are not welcome. And I thought that I could convince them. I thought I could say, I apologize for past transgressions, but now it's me. Look at me. I'm a researcher of color doing research in communities of color. But the rift was so great that it didn't happen. And I had to be respectful of that. And I had to think of ways to overcome those barriers. So I have several projects that I have worked on, and one example is through the Robert Wood Johnson Healthy Eating Research Grants. I've been able to look at statewide beverage policy implementation within the early care and education setting. And in this approach, or with this grant, I started by working with the Department of Early Care and Learning, and I also worked within a framework of a large Head Start grantee within the state. But instead of coming in and saying, this is my grant and this is what I want to do, I started off before that simply volunteering, simply serving on the health advisory board, doing different types of projects for the young children that related to nutrition, asking them their opinions and their thoughts. So by the time we got to doing something that was a statewide approach, where we needed to have networks of people and use a systems approach, we were already in relationship. We had already built a rapport, and they already knew how much I valued them and also all of the assets that they brought to the table. I'll give you another example in terms of working with the Food Bank of Northeast Georgia. I was talking to a colleague about a need to serve where they have a wonderful program called a mobile school food pantry that delivers fresh fruits and vegetables and other produce and meats and different products to low income families within the Northeast Georgia region. And they needed someone to do food demonstrations. And so I said, well, we have students, and we created a service learning project where students go out and do things like teach people how to put kohlrabi and lo mein that they make from ramen noodles, but they exclude the salt pack. And so just being able to be there to serve a need, to even go away from my desk, get out of my seat, and go to the food bank and volunteer and roll up my sleeves has been a wonderful way to build a bridge to simply let them know, I understand, I see what you're doing, and I would like to contribute. I would like to serve before I ask. And so through all of those things, over time, I have the privilege of serving on the board of directors for our food bank and just helping to move the mission forward, but first rushing to understand the mission before I sought to go in and make changes or bring my own solutions. And I've already told you about the immense need within the Athens-Clarke County, just within the area, within the community. And so we have to be seeked in this. And what I think about as I go forward is the importance of understanding inequity. So that quote is so important. And when I think about that, I think about the tradition of the African griot in African culture. And the griot is the person that is the keeper of stories. And so if you look at this picture, you see people sitting at the feet of this griot and telling as he tells the stories. And sometimes we have to be willing to sit at the feet of our community members. We have to be willing to sit at the feet of those who are leaders, those who are young, those who we think may not be bringing certain aspects or certain assets, but they all have value to bring. And I have had the privilege on the other end, we have to think about equity in the researchers who are leading this type of work and can connect with the community in a special way because of their experience. And I've had the privilege of having griots like Leanne Birch and Shariki Kumanyika, where I could sit at their feet and learn from them. So I challenge you to think about how can you be a griot to move toward health equity for others. And when you think about that, I love the picture that Angela had in the beginning of her presentation that had the little boys looking over the fence. I don't know how well you paid attention to that, but at the end of it, it said liberation. It was you moved toward from equality to liberation, and a liberation meant no fence. And so I close with a quote from Lilla Watson. It's one of my favorite quotes, and it says, "If you have come here to help me, you are wasting your time. But if you have come because your liberation is tied up with mine, then let us work together." So liberation is no fence. So think about ways that you can break down barriers and leave the door open so that everybody in the community can work together, that we all have equal rights, that we're working together toward equity, and that there is no fence. Thank you so much. And right now, I'll pass it over to Shariki. I'm sorry.
Thanks, Kari. I'm going to do a quick introduction of Shariki. Shariki Kumanika is a research assistant professor in the Department of Community Health and Prevention at the Drexel University Dorfman Site School of Public Health and professor emerita of epidemiology at the University of Pennsylvania. Dr. Kumanika's research focuses on identifying effective strategies to reduce nutrition-related chronic disease risk, with a particular focus on achieving health for Black Americans, and she's the founder of the Council on Black Health. So I'm going to pass it over to Shariki.
Thanks, Angela. So I'm delighted to be a part of this panel and to share some of my ideas about how we can improve the equity impact of our work. Thanks to Kari for the kind words and the tall order. She's described me as a griot, so that means that I have to really have all the answers. I don't have all the answers, but I do have some ideas to share in the form of a framework and a tool that I've developed. So as you know, we have been trying to provide you with answers to this question. So what do I do next? Some of it might be a little bit daunting. Some of the social science concepts and things that you probably didn't study if you were studying community nutrition. But what I'm hoping to do in this presentation is to help you develop your own personal comfort zone with how do I approach this type of work and systematically go through a process that will increase the chances that I can have an equity focus or an equity impact in the work. And so you'll hear a lot of things that should resonate with what you already heard before. So the name of the framework, not surprisingly, is Getting to Equity and Obesity Prevention. It was developed at the request of the Healthy Eating Research Program. Not the framework, but the tool that I'm going to present later. It's available in at the link that I'm showing you on the American Journal of Public Health website. And if you access it from this link, you will also be able to access two supplemental files. One is from an excellent CDC resource on some of the how to achieving health equity. And the other is the tool that I'm going to talk about at the end of the presentation. So this is the framework. It has these 4 quadrants. The 2 at the top are related to interventions, and it's designed for policy systems and environmental change interventions. And the 2 at the bottom are related to people. So at the top left, you can see some examples of interventions: food retail and provision, schools and worksite food. Some of the things that I think many of the people attending this workshop will know about, and these are the types of interventions that we're doing in communities to change policies and so forth. This is a generic framework, so you'll also see examples here about physical activity and those types of interventions. At the top right are things that could counter the effects or detract from the effects of the interventions that are on the left. So if you're trying to promote healthy beverage consumption, the promotion of unhealthy products is going to be a problem, a deterrent to promote to the ultimate success of your intervention in increasing beverage consumption. Or if you're dealing with neighborhood retail and food access, you will be thinking about the cost of the food, the threats to personal safety. And so all these things will be a part of the big picture of your intervention. And if you're only doing the one intervention without thinking about the others, you may not have the success that you want, especially from an equity perspective, because the things on the right-hand side are particularly relevant to priority populations for equity. So now if you look down at the bottom, you'll see nutrition assistance programs and things that are labeled improve social and economic resources. On the right-hand side, build on community capacity. The point here is that when you think about your intervention, there may be other things that are impacting on the person's ability or the community's ability to benefit from this intervention. There may be competing demands, lack of resources, work schedules, or really other priorities that are preventing people from engaging with your particular intervention or benefiting from it. And on the community side, the type of community in terms of food activism, there's some communities that are very activated on food justice, some are not. There are partnerships going on in communities. There are all these assets in communities that one could build on. And the behavior change knowledge and skills and healthy behavior promotion relate to the individual interventions that go on in communities to try to bring people to some of the healthy interventions that we might offer. And those individual interventions are still very, very important in the overall scheme of things. So at the bottom line, the point is that the likelihood of achieving equity is going to be greater if you can either include or account for something in every quadrant. And that's why the little scales of justice are there. We're looking for synergy on the equity issues with this framework. So I will go to the. So picking up on some of the concepts that you've heard from the other speakers, overall, in order to increase the equity impact of your research, you have to acknowledge the historical oppression and structural racism as underlying drivers of inequities. You have to not believe that the people that you're trying to help are irrevocably broken or unfixable or to blame for the things that they don't have. And we can't say this too often because, as you've heard, the other narrative has been sort of baked into our society. So we have to acknowledge where some of these inequities come from. And then we have to identify them in relation to settings, in terms of people, their life circumstances and their realities, and the intervention elements, and how the interventions are assumed to work and whether those assumptions are valid. We also have to consider the threats to effectiveness of any particular intervention. And we'll talk about that more when I talk about the healthy eating research tool that I developed for looking at research design, research proposals, and we have to do all these things in combination. So it's a tall order and it's quite challenging. But I think we're up to it. We have to be up to it because the alternative is not acceptable. For settings, this is a tool from my, or a framework from my colleague Boyd Swinburne in New Zealand, of how you deconstruct the environment. So you're going to think about the setting and whatever setting you're in, if it's the economics of a situation, you're working with a low-income population, is it the physical setting, are you looking at policies or the social cultural environments, and then dividing the micro environment and macro environment, or separating them as different levels of intervention and then saying, okay, in the near environment, what's available? What are the financial factors? What are the rules? What are the attitudes, beliefs, and perceptions? And in the bigger environment, you ask the same questions. So that's a clue, and this is all explained in the paper that I mentioned on the slide. So since I've written more about this, I'm not going to dwell on any of these things, but try to point you to these as guides for your own thought process. So the people perspective is the one that I think really caused me to develop this framework, because we had become very enamored of changing the environment, and at some point overcorrected and forgot all about the people. So we have to ask, who are the people in these settings, and how are they different from the communities where the interventions might have worked? And we do see examples, several examples of interventions that work very well in some populations, but not in priority populations. So we ask these kinds of questions. We look for co-benefits other than unrelated to obesity or nutrition. And we look for liabilities. We look for negative, unintended consequences that we should be careful about before we dive in and try for community change. And from the intervention perspective, we have to deconstruct this as well. And there's some new techniques that people are using to actually deconstruct interventions and breaking them down into their parts. But you want to know, like, okay, first of all, is it relevant to this population? And then if it's relevant, what's the primary pathway? How is it supposed to work? You have an assumption that may or may not have been articulated. And then, is that assumption met in this context? Maybe in the place where the intervention worked, people were providing other things to make the intervention work. The parents were driving the kids to a particular place to get something that you wanted them to have, but maybe that's not available in this community. So how is it really supposed to work? And then what contextual factors or other interventions might adversely affect, again, what's the noise coming from the other side, and what can you do about it? How can resources and capacity be enhanced to improve intervention effectiveness? So now I'm going to turn to the tool, and I'm going to explain the tool first. The tool is a series of questions that prompt for evaluation of a proposal along the usual lines of a proposal, and they help you think about each aspect of a proposal in terms of what population is being studied and why is this particular topic of relevance to that population, if it's a particular priority population or a diverse population, what's the intervention, and so forth. It's based on concepts in the Getting to Equity framework and that type of thought process. Underlying rationale and principles are there as well. And again, I would suggest if you go and you get supplemental file B from the website, look at the appendix first before you look at the tool. So what's in the appendix? Some definitions that I thought were important, definitions of health equity, of priority populations for equity considerations, and some criteria for research that could have an impact on health equity, a negative impact, positive impact, or will not have an impact on health equity. And then characteristics of the different types of studies that are, or aspects of research that might help you with the equity impact. And the potential factors that influence the relative effectiveness of a PSE intervention, I go into in more detail, and for each one I mention what the issue is, give an example of it and its implications, and I'm just going to briefly show you these issues, and I'm not giving the examples and implications, but I wanted you to see what these issues are. So an intervention could be less effective or more effective if it has a different role in or leverage in a particular population compared to the reference population. If it's just one example of an example. So if something is offered at school or after school, it may be more important for children who don't have those resources at home, and that intervention might work better in that population because you're providing something they wouldn't otherwise have. And that's actually been seen in the literature. Differential salience is the relevance, is it meaningful to the population? The reach, did it actually get to that population? Even if in the geography, did it reach the people you wanted to reach? The intensity is a matter of dose, but I'm pointing out here that if you have a lot of noise, like when I mentioned the healthy beverage issue, if you have a lot of marketing for something and you're trying to change consumption of it with a policy in that area, you may have to have a very strong policy to overcome the noise that's coming from marketing of unhealthy products. Feasibility, I think, is pretty straightforward, and the side effects, well, I'm saying it's straightforward, but these are all things you have to think about. Is it really feasible? That's, again, what does it take for this to work? Because if it requires something that people don't have, then it won't work. And the side effects, and they can be positive or negative. So there will be, if you're working in a community setting or in a broader policy setting, there will be other effects of that policy, and you want to make sure that they are not harmful to the community. The one that comes up all the time is displacement of the population you wanted to help. When you put in a fancy supermarket in that community, and then the people who were living there before all of a sudden are being pushed out because the property values have changed in that community. That's just a very simple example, but there are others. It could work to benefit. You could be bringing in resources and lifting the community up even more with the intervention. And of course, those are the kinds of side effects that we want. So the last slide I have here is just to show you the tool. I encourage you to look at it and think about, as you would write a research proposal, if the reviewer had a set of questions. This is basically a checklist I'm showing you on the left. Questions that would ask, like, how much does this researcher know about the equity issues in this population, and how have the aims been focused in order to have an effect on this population? So I won't go through any more now, but this checklist is there. It goes through all of the elements that are in a healthy eating research and many other types of proposals. And the idea is for you to think about it so that when the reviewer looks at the proposals, the answer will be great, 5, excellent, well done. So I will turn this back over to Angela for the minutes we have left for Q&A. And again, thank Healthy Eating Research for the privilege of being a part of this.
Thank you so much, Shariki. So we have some time, just a few minutes for questions. I also wanted to clarify, I said Carrie Cartwright, but it's Carly Cartwright. I want to emphasize that because she is my esteemed colleague, and make sure to clarify who I've known for many years. But I also did that at the other presentation. So I wanted to, she's even, and she says it's okay, but I'll make sure to emphasize that. So we're gonna, we have a few minutes for questions. I know the panelists have agreed to stay on and take questions. And so I'm gonna turn it over to Megan. She is going to field the questions for the panelists.
Great, thank you. And thank you everyone for those wonderful presentations. You'll see on the slide in front of you some more information about where you can find the slides and recording after as well. So one question we've had come in is really around this idea of, does it take an equity consultant or a person of color on every research project to do this well? And with more funders requiring that researchers are engaging community members, Should we be paying them or compensating for them for their expertise when developing equitable research methods, communications, et cetera? And anyone can feel free on the panel to jump in.
I mean, I will say that I think that people should be paid for their work. I think that an equity consultant should be a required part of every research branch. I know that some grant proposals require things like having a lawyer to ensure that lobbying is not being conducted on a research project or a particular project. And I see this as no different and just as important. And so I think funders should actually build in a funding line item for every proposal that a trained equity consultant complete the work. And if the work is being completed by a group or there are kind of a community engagement process that actually builds the tools from that ground up, through that mechanism, I think that should be the consultation fee that's built in.
I also want to acknowledge that oftentimes so I can speak from the epidemiology field, we decide that there's a content level expert that we need to bring in, and that we should treat health equity in that same regard. So whether the health equity consultant that you're bringing in is a researcher, or it's a community board, or a community leader, those people should be brought in as content level experts and compensated for their time. Oftentimes we ask people to just participate in our study and just like figure out, out of the goodness of their heart. And often many of us are so invested that we do it, right? We do volunteer. But I think it reinforces inequitable relationships between researchers and community members or people of color or kind of valuing people in different ways, so, different disciplines. So I'll just leave it at that.
Anybody else want to weigh in on that question? If not, I'll toss out another one. This individual is hoping some of you all could elaborate on the use of language around equity, inequity, rather than racism and anti-racism. Does using equity minimize the pervasive racism that exists in our academic system?
If nobody wants to take it first, I will start. And I think that as we go along over time, there are going to be terms that are often co-opted or kind of transitioned to mean other things than what they were intended to mean. I think with health equity, that was one of those things. I think right now we have reached a point where we do need to be specific about our language and racial equity, making sure that we're talking about racial equity and that we are emphasizing what we're actually referring to and thinking about anti-racist practice. And I think also being very specific about anti-Black racism, which I think sometimes we leave out or we assume that that's a part of it. But in many settings, anti-Black racism is a key element to talk about, especially in the context. So I live in Miami, Florida, where we're tackling quite a bit of anti-Black racism within the Latinx community. We have to be able to recognize what the precise issue is for whatever element of the work we're doing. But then I want to make sure that we're doing that from a critical race theory lens, which also allows for intersectionality. It allows for other identities. It allows for other systems of oppression. So you can do those simultaneously, and ideally, that's what we mean by health equity.
Yeah, I think that's really important, and it's something that Shariki raised in a previous discussion about looking at models and theories of people that really lean in and dig deep. And I think critical race theory is one of those. Uh, we sometimes create models within our subfield, like within nutrition, but it's important to look at those theories, as Dr. Bailey talked about, uh, looking at critical race theory, and then how do you apply that to nutrition, or how do you apply these framings to another, I say another area, but it actually could be applied to any area. Uh, but sometimes we kind of start from scratch when we think about equity versus bringing in these really very well developed theories and frameworks that focus on things like racism, or there's others that focus on heteronormativity, or, and so critical race theory does account for intersectionality. So I think sometimes we have to get out of the box that we're in, look at some of these other things, and then figure out, have some discussions about how do we apply them to achieve health equity within our particular context.
Well, I can add a comment on that too. I think that the more we learn about racism in terms of the specific policies and practices that have been used to create the situation we're in now, the more people may be able to accept the term, because they'll see that it's something that you can do something about. It's not this big, cloud hanging over everyone, but it's actually a set of pretty specific things, like, laws that prevented people from being able to buy a house. That's very specific, but but having that law that you can't buy that house if you're Black is racist, a racist policy. And so I think we should, I know the term upsets people, and I tend to be, wanting to leave people, some cover, but if we can break it down and just deconstruct it and think about it, which is a lot of what critical race theory is talking about, I think we would really get farther than if we try to suppress the term.
Yeah, and I know we probably have to go to the next question, but really, when you look at those policies, I think what Shariki says is important, and what Dr. Bailey mentioned is very important, because it's hard to do work in African American communities if you have an anti-Blackness. We don't always realize that we may have that anti-Blackness perspective, that we're walking around with that. Or as Dr. Bailey mentioned before, the idea of white supremacy. Most of us wouldn't, of course I wouldn't, but most of us wouldn't think that we have those beliefs around white supremacy. But they're so deeply rooted in science, and they're so deeply rooted in American society related to Black inferiority. It's so important that we challenge those work. And a lot of times we don't realize that they're there. So the first thing is really to sort of, do I have an anti-Blackness perspective? And even Black people, around the thinking of internalized racism, the idea that you may have, because it's so pervasive in society. And so it's important to challenge those white supremacist ideals and anti-Blackness, or whatever population. Do I have a heteronormative framing? But now I'm here doing research with sexual minority populations. It's important to challenge those things.
Great. I'm going to choose one last question, and it's not an easy one, so I'm giving you some forewarning. But building on where this conversation is going, what are ways we can shift policy and government officials to look at things through an equity lens rather than just equality? And I think you all have done a really good job of laying out the research and the importance there, but I'm wondering if you can elaborate on that question as part of your closing comments.
Well,
go ahead. You start, Sharika.
I was just going to say something very, very quickly, because it's something that comes to mind. I think if we can show policymakers who is advantaged by certain policies, it will help. I think about paid sick leave and the ability to breastfeed or the ability to stay home during COVID and stuff like that. The people who are advantaged are the people who are a lot less likely to get COVID or to be able to breastfeed if they want to. And so maybe focusing on the advantage that that's giving people will help policymakers see that it's not an equal policy that we need, we need an equitable policy.
I agree with that. And when I think about the shift, again, I think that we have political will and demand from people. And the more we drive and we talk about the terms and we use the terms and we think about what is needed to even get past, the equity, but go toward liberation. And I just love that. I love seeing no offense at all. So how do we do that and do that effectively? And one of the examples is Robert Wood Johnson Foundation to have required in grants and to require researchers to get out of the box and to focus on these things as a part. Because I think if it's not a critical policy, if it's not something that's required, it doesn't force people to move toward that. And so I think we have to push the needle. We have to create the emphasis for people or the catalyst for people to move toward that. But Robert Wood Johnson Foundation is an excellent example of how to start because it's an influential organization and it can start momentum and others hopefully will follow suit.
As a follow-up, I would say that essentially, I think there's elements or reasons or ways that we can broaden or widen the lanes that we are working in. So I would say that the subject, the audience of research should not just be the policymaker or people who may talk to the policymaker or even journalists. I think sometimes you're going to need to share information with citizens, the people who are most affected, the people who are driving the content of the research towards understanding what you have studied, what you have found, and how to mobilize their elected officials and others to act in their interest, right? So being able to mobilize people with data, with information, with context, to be able to act on the key information that's being found. I think there's a level of democratizing of data and the results of research that can happen that can feed our democracy and feed equity from a structural level.
Yeah, and I know we are out of time, but the critical piece of storytelling in this and how people tell their own stories, how can we facilitate, particularly with policymakers, how can we share those stories? I think Shariki mentioned in making sure we convey who is advantaged, who has an advantage and who has a disadvantage, and how critical it is to have narratives and facilitate storytelling from the people that are most affected, for people to be able to tell their own stories through data.
Yeah, and I would just also add, and sometimes it's, I can speak as a white person, it's getting out of the way of those stories and letting the people who are impacted tell the stories, and possibly having the people that are impacted in those positions of power and then following their lead and amplifying their voice. So getting away from white centering and kind of recreating a white supremacist system and the existing kind of governmental structures, and possibly listening to the voices of those that are most impacted in the BIPOC community and focusing on what they're saying to do, and then doing that.
So much for your wonderful presentation today. It's been a fabulous webinar, and thank you to our participants who have stayed on past our scheduled time. We really appreciate it. This is the first in a series of several webinars on this topic that we are planning to do in the coming year. So we really encourage you to sign up on our website to stay up to date on our work and future webinar opportunities, as well as the webinar slides and recording will be available at our website following. We've also had a couple of requests for listing out some of the research articles and citations that our panelists had in their presentations. We are happy to pull together a bibliography for you all that we can also post on the website. And we've had some other good ideas come in the chat box as well about ways to stay connected that we will be sure to make sure we post more information on our website. So thank you so much again. We look forward to future conversations and we hope you all have a wonderful afternoon.